Hello, everyone. I'm Dr. Catherine Kennard, the Preventive Medicine Medical Advisor for the Illinois Department of Public Health, and I'm really excited for this month's PHACT session, Health Habits and Habitats, the Roles of Frontline Clinicians in Occupational and Environmental Exposures. I do want to mention that I have to give you the CME accreditation statement. The Illinois Department of Public Health Medical Services Division is authorized to offer formal programs of continuing medical education to Illinois physicians licensed under, you see the law there, the Medical Practice Act of 1987. And our programs do comply with the criteria that are in the administrative code. And this course may be used for Illinois registered nurse relicensure. Each licensee is responsible for maintaining records of completion of continuing education and shall be prepared to produce the records if requested by the department. And we will update that slide to say 2025 now. We do not have any financial disclosures for the team presenting today. And here's our learning objectives. Upon completion of the webinar, participants will learn about the IDPH toxicology section, increase knowledge of environmental and occupational exposures in the public health response, learn the basics of taking an environmental and occupational exposure history, learn common exposures and symptoms that may affect patients presenting for evaluation, and receive resources for incorporating environmental and occupational exposure histories into clinical practice. I am facilitating, obviously, and our first presenter is going to be Erin Martin, who is the Environmental Toxicology Section Chief at the IDPH Office of Health Protection. And next, we will have Linda Forst, MD, from the University of Illinois, Chicago, occupational medicine specialist and professor of environmental and occupational health sciences. So with that, I am going to stop sharing and we will let Erin take it away. If you have questions during the presentations, please go ahead and put them into the chat and we will do our best to get to all of them by the end of the session. Thank you.
Thank you, Dr. Kennard, for not reading my entire bio and embarrassing me. Can you see me okay?
We can.
Okay. So, hi, everyone. Thank you for having me. I'm a first-time presenter here. My sense is, I had a conversation with Dr. Kennard back in the fall, and I volunteered to come and talk to the medical services division just because I kind of felt like we were going through some investigations and maybe there would be some value in talking with that group and perhaps others, just giving an orientation to our small, perhaps not well-known program. I think that you may have more experience working with one of our sister programs, the Illinois Lead program, since childhood lead poisonings are reportable, but we're not regulatory and we don't have any reportable diseases and conditions. So we may not be someone that you work with frequently as a healthcare provider, but when you need us, you need us. And so today I'm just going to walk through, give you, probably going to go down a few rabbit holes here and there, but try to give you an overview, a high-level overview of our section and program activities. We are a small team. In addition to myself, I've got 2 health assessors and a public health educator that works for the program. And fingers crossed, in early February, we're going to be onboarding an indoor air quality specialist who can focus on that and that alone. So we have a couple of underlying statutes that support our work, but we have 3 core areas of responsibility that we work on. Excuse me. We, through a cooperative agreement with ATSDR, conduct public health assessments for hazardous waste sites and releases of hazardous materials. We maintain and publish an annual fish consumption advisory update, and we provide consultation and technical assistance related to indoor air quality. The emergency preparedness and response is somewhat it's part both of our indoor air quality activities and part of our health assessment activities. So I almost need to apologize. We spend the largest part of our funding that supports our staff comes from a cooperative agreement with CDC's Agency for Toxic Substances and Disease Registry. That's ATSDR for short. But I only have this one slide describing what we do. We are in the middle of a 5-year funding cycle with ATSDR, and that supports 2 FTEs or 2 full-time employees in the program. Through this cooperative agreement, we conduct both site-specific assessment activities and community engagement activities. The largest part of the work is preparing public health assessment products for sites that are either on the national priority list or Superfund list. We respond to sites where the public has petitioned ATSDR for a health assessment. And we also work on sites that haven't been added to the NPL or Superfund list, but are being evaluated for it or are state priority sites. The sites I have listed on my slide here are just some sites that I excerpted from our current annual work plan. And they're a mixture of NPL and petition sites, but also a mixture of sites with different contaminants or types of products that we're going to generate. So if I could take a step back, a health assessment to me means something different than it might mean for a healthcare provider. The two primary kinds of health assessment products that we would write are called health consultations and public health assessments. A health consultation is a written evaluation of environmental sampling data for a site. It's usually targeted toward a specific question and is usually targeted toward one specific medium. So, in other words, is it safe to drink well water for a resident near a site? Or is a ball diamond where soil sample data have revealed elevated levels of lead safe for children or adult ball players to play on? These documents become public documents, and they would include conclusions about the public health risk that a site poses, as well as recommendations for the public for things like reducing exposure, or we may issue recommendations to regulatory authorities for further site evaluation or methods that might be imposed on a responsible party to reduce exposures, like installing a drinking water treatment system. Where a public health assessment differs, I should say most of the work we do would be health consultation products. A public health assessment is usually a much larger, broader focused document that looks at multiple routes of exposure to contaminants at a site, perhaps multiple media. So instead of simply looking at residential soil or well water results, we could be looking at exposures to on-site soil and mine tailings, exposures to metals and wind-blown dust, as well as well water, fish, or surface water exposures at a single site. Another important difference is that a public health assessment is going to go out for public comment, which we would respond to before final publication so that we can address the public's concerns. I think an important piece of knowledge, perhaps, that I'll add to that before moving on would be that for certain sites or for sites where there are health concerns for things like lead or other contaminants, it's routine for us to recommend that citizens with health concerns should talk to their healthcare providers about exposures that they have at the site. We may also add to that a recommendation that they could consult with the Occupational Environmental Medicine clinic at the University of Illinois, Chicago, or this is a good place to mention that our partners at ATSDR, in addition to funding states like our own to do hazardous waste site assessment work, they fund, I can't remember how many, maybe 10 or 9 regional pediatric environmental health specialty units to provide citizens with medical and doctors with technical assistance and consultation. Okay, another area that we have would be the Illinois Department of Public Health partners with the Illinois Department of Natural Resources and the Illinois Environmental Protection Agency. Historically, also the Department of Ag we partner with these other agencies on the fish contaminant monitoring program. So each year, the Illinois Department of Natural Resources goes out to Illinois lakes, rivers, and streams, and they collect samples of fish tissue, which they submit to Illinois EPA's lab for analysis. In addition to providing the lab services, Illinois EPA usually takes the first crack at proposing advisory updates. And then we meet around this time of year normally before IDPH puts out an annual press release with advisory updates. We also, as part of our outreach and education efforts, maintain a fish advisory webpage and map. And if I could do this without totally botching things, I'm going to stop sharing my slide deck. And I'm going to share. Oh no. Can't see. Oh, here we are. There we go. Okay, can you see that, Dr. Kennard?
It's still loading,
Okay.
but hopefully we'll pull up in just a minute. I guess you could describe, there we go. Okay, now we can see it.
Yeah, so we have built this web page and map for anglers and fishermen to be able to check the Illinois fish consumption advisories for wherever they happen to fish. If you're someone like me and you like to print the internet, down here under publications, we actually have available a hard copy of the fish consumption advisories. But the thing I really wanted to feature is that we have this map. It's not a GIS map. It's pretty simple, but you can click on the map county and it will pull up a list of all bodies of water in that county for which Illinois has a current fish advisory. So I'm led to believe it might be yellow perch season. So let's say you want to go to Lake Michigan and do some fishing for yellow perch or salmon or what have you. You can navigate this page. I apologize that this is slow to load. And it will take you to a page where you could see visually each fish species for which we have established a consumption advisory, along with any length based advice that might apply. So, for instance, we have for all sizes of yellow perch a 1 meal per week advisory for mercury. That would be for the general population. That would be people, males, people beyond childbearing age. But for women and children of childbearing age, we do have, in this case, it's the same. It's a 1 meal per week advisory for mercury, but we also have issued an advisory for PFOS. So, bottom line, you could go to the map, you could search for it online by typing in Illinois Fish Advisory map, and you could get a listing of fish species, meal frequency advice, and contaminant information related to that lake or river. Now I'm going to stop. And I'm going to jump back to my slide deck. And there are two changes or highlights that I want to talk about to the fish advisory program that have happened in the last 2 years.
It is loading. And I wanted
Okay.
to mention you have 10 minutes now.
Oh, gee whiz. So I need to just start talking. And hopefully it will load back up. There we go.
And we are seeing your presentation.
Okay, so I need to say that as far as the fish contaminant monitoring program goes, we currently are testing fish for PCBs, methylmercury, and PFAS is a recent addition. Based on historical monitoring results and just not finding levels that warranted do not eats or fish advisories, in 2023, we announced we would be discontinuing organochlorine monitoring of fish. Nevertheless, we still, while we're not testing for it, we do maintain 3 what we call zombie chloridane advisories for Lake Decatur, Taylorville, and Highland Silver Lake. We have not been able to get sufficient sample data to be able to relax or rescind those advisories. Last year, for the first year, based on a new capability at the Illinois EPA lab, we started testing waters for PFAS and issued advisories, including at least one do not eat advisory for 9 lakes and rivers in Illinois. And I would expect that when we do our advisory updates this year, that we're probably going to have more waters with PFAS advisories. So, what are PFAS, you ask? Those are per and polyfluorinated alkyl substances. They could be short, they could be long chains of carbon that are kind of saturated with fluorine molecules. And that carbon fluorine bond is really tight and really stable, so these chemicals tend not to break down in the environment, hence the slang term forever chemicals. These products are used for their water and stain resistance. They've also been used in firefighting foams. We see them at some of the sites I didn't mention earlier in my talk. And your patients, ourselves, we could be exposed to PFAS in drinking water. They're found in food. FDA finds them in certain types of products as part of their total dietary study. You may also see them in food packaging materials, local fish, and they do break down and can be found in indoor settled dust. Here, I just really wanted to highlight or underscore the messaging from the last slide about the presence of PFAS in drinking water. And what's more, our partners at EPA did testing of every community public water supply in Illinois from 2020 to 2022. And they found that PFAS were detected above the advisory levels we were using at the time in about 5% of the supplies. So keep this map in mind. The blue dots recommend not detects or levels for which PFAS were below the advisory levels. The red dots and the yellow dots are all places where they were detected, either above or below a reporting threshold or guidance value. So what can we and our patients do to reduce our exposures to PFAS? Public water supplies are tested, and going forward, they're going to have to meet newly established maximum contaminant levels, but you can install point of use filters on your kitchen sink or on your refrigerator dispenser. They should be certified by NSF for the removal of PFAS. If you have patients that live in areas where PFAS have been detected, i.e. the red and yellow dots on that map, if they're using a private well, they really ought to be testing for PFAS. We can help people who call us identify labs that will do that. In a limited number of cases, we have the capability to go out and do testing. They can also check our state's fish advisories, and I put a bullet on here about talking to your doctor about PFAS testing or screening, and want to make a point that couple of years ago, the National Academy of Science and Medicine came out with a framework, a 3-tiered framework for evaluating blood test results for PFAS. On the indoor air side of the house, we have a public act that was passed in 1994 that charged us with developing state IAQ guidelines, recommending measures to achieve acceptable indoor air, and providing outreach and education to the public. One of the things that, for reasons unknown to me, we never did establish a certification program for IAQ inspectors, but that was a fourth piece from the act. So everybody's favorite part about the indoor air program, we take complaint calls from the public, usually about 250 to 300 per year. And historically, for the last 20 to 25 years, about 40 or 50% of those have been mold related. And I would say at least half, if not 2/3 to 3/4 of those are mold complaints related to rental housing. And they all look quite a bit like this. Hey, I've got visible mold in my apartment and my landlord isn't doing anything about it. I talked to so and so and they said that you could come out and test or do an inspection. And that puts us in the tough spot of trying to correct that misconception. Usually, the way we handle these, we just don't have the staff or the time to go out or the authority to go out and do an inspection for every complaint that we get. So we do a sort of virtual inspection, ask them questions on the phone. Where do you see it? What is it on? Can you give us more information about whether you're seeing dampness or moisture issues or what that issue might be, with an eye towards referring them back to their local code enforcement agency for a local code enforcement inspection. Mold is not usually a part of property maintenance codes, but issues that cause it to grow in houses, like a plumbing leak, roof leak, those kinds of issues usually can be addressed through local code enforcement. For the year ahead, it's been probably 15 years since I last updated the IAQ guidelines, so that's something that we're going to be working on this year. There also was a bill that passed the legislature in 2024 that will require us to establish procedures for mold remediation contractors to register with the state and provide proof of an active third-party certification. So we're going to be working on that. We do a limited amount of monitoring or indoor air investigations, and among those, mercury spill responses are probably the most routine thing that we do. We don't do as many of these as we used to, but we receive reports from partner agencies and law enforcement on clandestine meth labs. And as part of that, issue property owner notification letters. And if we receive testing data, we could do a post cleanup clearance letter for that property owner. Two things I wanted to plug on the outreach side. One of them is IAQ related, the other more site related, but in each of 2023 and 24, we did a free lead in soil testing event here in Springfield. And I would like us to do another one or two events in 2025. But we would be looking for partners to help us host a so-called soil shop event to do that. We're also working with US EPA. They're going to be delivering materials to us so that we can do 2 to 3 DIY air cleaner workshops in 2025. We're going to be, as part of that, presenting information on wildfire smoke and both outdoor and indoor air quality. But as a part of the workshop, we're going to bring supplies and train people on how to build their own box fan air filter style cleaner for their homes. Here are the names of our staff and where to find us. If you have some questions, if you want to refer one of your patients to us for possible assistance, if you have questions yourself, you could reach out by phone. We also have a program email, which is dph.talks@illinois.gov. And I've listed here our the URL to our program's website and all of our materials. Dr. Kennard, do I have time to
Well, you're
run?
2 minutes over, but I think if you could just do it in like 2-3 minutes, maybe that would be fine. We don't want to cut off Dr. Force too much, but thanks.
Okay, so I've got a case study here, and I probably don't have time to go through it as slowly as I might normally do, but we do mercury spill responses, and mercury spills are always very interesting. And so I have some slides just describing one of the larger spills that we did in Knox County 4 years ago. This gentleman, older guy, his sister died, and so he had her stuff shipped to him here in Illinois. And one of the items was an antique barometer. Antiques are always a problem for us. But he, sometime between September of 2019 and December 2019, he noticed he had the barometer on his kitchen stove, and he noticed that it was leaking onto the stove top. He did what he could to clean it up. And then was unsuccessful at trying to dispose of the barometer locally. For some reason, he went to the doctor. It could have been an annual checkup, but I don't recall him reporting any symptoms. But his doctor, between February, March, and May of 2020, did blood testing for mercury and found levels that ranged from 44 to 20 and 49 micrograms per liter total mercury between that February to May timeframe. For reference, we would usually compare a blood or a urine result with the with the numbers in CDC's biomonitoring tables. So for reference, for mercury, total mercury in blood, the 95th percentile value for the US population is about 4 micrograms per liter. So even without symptoms reported to his doctor, his blood level of mercury was about 10 times higher than that 95th percentile. This is going to be on the test, but we do have an SOP for responding to mercury spills. Perhaps the most common type of spill or source of spills referred to us would be fever thermometers, science thermometers in a high school chemistry lab, or fluorescent light bulbs. Historically, we didn't do mercury vapor monitoring for those, but we've started to go out almost routinely now. And I think that's probably been a good thing because we usually find in our initial visit that initial efforts to clean up the spill were not successful. But it's been our experience that spills related to blood pressure devices and barometers tend to be big, they tend to be messy. And so we plan on doing field visits for those particular sources. And then lastly, we will do a field visit in situations where a resident or a physician reports clinical test results to us. And that could include situations where the exposure source is known, such as a broken mercury containing advice or skin creams, or we've even gone out in an instance where a citizen had some blood testing done, but they didn't know what their exposure was. We screened the house using our mercury vapor analyzer, and normal background is usually less than 0.1 micrograms per meter cubed. Our action level is 1. That's a level that we would use to clear a house. This guy's house, months after the fact, was smoking hot. Throughout his house in a breathing zone, we were picking up levels approaching 40 micrograms per meter cubed. And we did find some additional liquid droplets of mercury beneath the stovetop where he initially reported a spill. In the end, we requested that our federal partners at US EPA, through their emergency response and Superfund program, if a homeowner doesn't have insurance coverage, or if the responsible party doesn't have the resources to clean up a spill, we can actually request that they come out and provide cleanup assistance. So it became apparent very quickly that this homeowner wasn't going to be able to bring his own resources to bear. He didn't have the insurance coverage. So we requested EPA assistance, and they spent about a month cleaning this house up until eventually the levels were below our action levels. And in conclusion, we also a blood sample taken a month after he had relocated from his house. The numbers were lower, but still not as low as we'd like to have seen it. So we had recommended to him that he continue to visit his clinician and do a recheck of his blood mercury levels just to make sure those numbers come down. And that is my last slide. I feel like I rushed through that and covered a lot of territory, but thank you for giving me the chance to present.
Thank you. So we will now move on to Dr. Forst. Thank you, Erin.
I think you have to stop. Okay, there we go. Hold on 1 second. Sorry,
I think I have your slides up, ready to go, if you want me to run them, or
okay, yeah.
I know we're a little behind.
It's just churning on my end.
Okay.
I'm trying to share, but it is churning.
Yeah,
So I don't mind if you try.
Okay, are we seeing
Yeah,
your presentation?
yeah, that's fine. Great. Okay, so this is me. Thank you. Next slide, please.
Oops, I'm sorry. I think I grabbed my wrong slides. I'm going to close the introductory slides. Apologies to everyone. We will have this up in 1 second between the two of us. All right, now I'm going. I'll be cooking with gas here. And we will put this in presentation mode. Okay, ready?
Okay, that's great. So This is me. I'm a faculty member at the UIC School of Public Health, and I'm also an occupational medicine physician at UI Health. I have nothing to disclose. Some of the work that I do is funded by NIOSH. This is
Leave it up there, but go ahead. Sorry.
This is an acknowledgement of the Native Americans who lived on this land traditionally. Next slide, please. By the end, you should be able to take an occupational history and also categorize occupational illnesses according to hazard types. Next slide, please. So I'm going to tell you a bunch of cases that maybe you've seen in your practice, and then I'll talk to you about taking a history and the important points to garner from the history. So this is a 48-year-old construction worker who went for healthcare complaining of a severe skin rash. Skin disorders are the most common disorders. Dermatitis is the most common occupational disorder that gets reported. He reported working with chemicals over time. Initially, he had occasional rashes that he treated with hand cream, but over the years, the rash became worse and worse, and it's not getting better. On the right side of the screen, I have a list of the chemical agents in the construction industry that are responsible for contact dermatitis. Next slide, please. This is a recent case that you might have seen in the Tribune. A father and son in Chicago were diagnosed with silicosis, which is a scarring lung disease caused by the inhalation of crystalline silica dust that gets emitted when workers cut or grind stone. Engineered stone that they were cutting is synthetic, and it contains more than 90% silica dust. Natural stone contains less than 40% and generally down to more like 5%. And so the dust that gets generated isn't as damaging, but if you inhale 90% silica content when you're grinding or cutting stone, it's very damaging to the lungs. These guys were treated by a primary care provider for years for general lung symptoms. Nobody thought, I guess, initially to ask about their work until they were already going to transplant. And then it turns out that they did this kind of work. Next slide, please. This is a 32-year-old factory worker operating a grinder in his manufacturing job for the last 10 years. His wife recommended asking the doctor to evaluate his hearing. It turns out that he had significant noise-induced hearing loss, and by history, he was exposed to high levels of noise in his workplace. So clearly, occupational hearing loss is a huge problem. Next slide, please. You may have seen carpal tunnel syndrome in your practice. A 33-year-old male butcher presented with numbness in both hands. They began 4 months prior to the visit, and they were progressively getting worse. The physician diagnosed carpal tunnel syndrome. The patient said that the pain is constant and severe and numb in character as well. It's aggravated with flexion and extension of both wrists, and the symptoms are worse at night. Those are very common symptoms. You may not know that forceful wrist flexion is the most common cause of carpal tunnel syndrome. A lot of people think they're getting it from typing on their computers, and there's more and more evidence that that is not happening. But people that work in manufacturing or do forceful work with their hands are more prone to this. Next slide, please. There was an outbreak of COVID-19 in a meat packing plant in Illinois in 2020. The local health department came in to advise the plant manager about preventive measures. We now know a lot about occupational COVID-19. So of course we know that the essential workers that worked in healthcare were infected, preferentially or at increased numbers and rates, but also people in meat packing. So essential workers, people that left home for work, those that did indoor work, they did work spaced close together, like on an assembly line. If their work was highly exertional and they were breathing quickly, they were more likely to inhale the virus. Sped up lines increases breathing and exertion, and so increases the risk. And no paid sick leave was another huge problem, an administrative problem. When people were sick, they didn't have leave to stay at home, and so they came to work sick and infected their coworkers. Next slide, please. Here's a roofer in the medical examiner's office. He was fastening shingles on a house. He stood up and stumbled, falling to the ground. He was not tied off. You see the guy in the bottom frame has a lanyard tied to the roof. So if he slips and falls, the lanyard catches him. But the guy above was working without a lanyard and was at great risk. This is not an uncommon injury or situation, unfortunately. Next slide, please. Here are two cases of dairy workers that got exposed to H5N1. These two were in Michigan. One developed conjunctivitis a day after milk splashed into their eye, and the second one developed a respiratory illness, more of an influenza type of generic illness with shortness of breath, sore throat, fever. There were cows that were sick in the workplace. This is a problem that is about to become bigger. It's growing as we speak. And so being aware of this, if you're working in a rural area, and if you work with dairy workers in particular, is a good thing. Next slide, please. So why is occupational health important? If those slides didn't convince you and you weren't convinced before you came to this webinar, let me just say that some diseases occur only in workplaces. Some diseases often occur in workplaces, so you could miss a diagnosis if you don't ask. Emerging, re-emerging diseases can be identified and controlled early. The next point is that work is a social determinant of health. So not only do people have hazardous exposures, physical and chemical exposures in their workplace, but having a living wage, health insurance, economic stability, work-life balance, self-esteem, self-efficacy are also important determinants of health and well-being. Health and healthcare providers and public health have the opportunity to prevent these diseases, so we should be on the lookout for them so we can jump in and prevent them. Next slide, please. And you might recall this from your schooling, that there are these three phases of prevention. Primary prevention is that you prevent the exposure before it occurs, and so you keep a healthy worker healthy. Secondary prevention is if the worker gets exposed, like that silica exposed guy, if his primary care physician had asked about his work, she or he could have stopped the exposure in the workplace, and that guy wouldn't have gotten such a big dose over time. So that would be secondary prevention. And then tertiary is the lung transplant, or trying to manage the disease once it's taken hold. Next slide, please. I want to show this to you if you haven't seen it before. This is the hygiene hierarchy of controls. Everybody knows our TLA, our three-letter acronym of PPE from the COVID pandemic. But PPE is a really poor preventive measure. It's really the last-ditch effort to prevent an inhalation or an exposure. What we really want to do is start at the top and try to physically remove the hazard or replace the hazard with a less hazardous substance, or enclose the hazard in a box, something like that. You really want to keep people away from the hazard. Another thing that can be done is changing the way people work, a so-called administrative control. You can do a training program. You can control their scheduling. You can rotate them through different job tasks so they're not exposed to certain hazards for a very long time. You can give them paid sick leave and tell them to stay home if they get sick. These are much preferable over providing PPE, although PPE is also important. Next slide, please. So let me just show you a little bit of data. Fatal work injuries in the United States in 2023 numbered 5,333. You can see at the top of this slide. Transportation and warehousing had the highest number, followed by construction and then agriculture. If you look over to the right, though, and you look at the rates, that is the number of work-related fatalities divided by the people at risk. You see that farming, fishing, and forestry occupations are the highest, and they've stayed the highest for many years, really. I'm just showing you three, but this is always the highest. This is always the order. Next slide, please. And then talking about non-fatal occupational injuries and illnesses by industry, in all industries, 3.2 million employers reported cases to OSHA. That's probably a significant undercount. 2.5% of those were in private industry, and again, construction, this time manufacturing, and other sectors are important. Next slide, please. If we had time and we were sitting in a room, I would ask somebody to volunteer and tell me about their work history. And I would type in all the hazards that I think are attendant to the job's tasks that they describe. And in fact, you could categorize every work-related hazard into one of these 5 categories. They could be chemical hazards, biological hazards, physical hazards, meaning noise, UV light, vibration, biomechanical hazards, that is the ergonomic stuff, and then psychosocial hazards, which ranges from long work hours, night shifts, deadlines, piecework, to bad relations with the boss and coworkers in the workplace. All of these items can cause adverse health effects, and they can be controlled in the workplace if one pays attention to that. Next slide, please. So how does a clinician take an occupational history? Maybe you guys all know Peter Orris, who's been in the public health and occupational health world in Chicago for a long time. But really what you want to do is ask your patients enough questions so that you can close your eyes and do their job. And what does that mean? It means that you imagine what they're doing physically as they're sitting there or standing there, and also what's around them, what personal protective equipment they're using, and other aspects of their work. And what I've found in the clinical setting is even the most inarticulate patients that I see become very articulate about their jobs. They care about their jobs. It's actually a nice way to connect with patients, to ask them about their work. And they really wax eloquent when they're telling you what they do in their work. I found that they really want you to understand it. Next slide, please. So here's a form that you can adopt. This comes from ATSDR, which Aaron mentioned in his talk, and you'll get the slide set, and there's the link at the bottom so you can download this and get it yourself. But really what you want to know is the person's name and birth date, their job title, the type of industry they work in, the name of their employer when they started their work. And if you're talking about an acute situation, then you want to know about their current job. But if you're trying to figure out whether, say, their cancer was caused by their work or hearing loss was caused by their work, you want to maybe get a more historical documentation of the kinds of jobs and hazards they were exposed to. So, excuse me, you can write them into this table. And then here's a list, a checklist on the back side of this one pager. And you can ask specifically what, if the person was exposed to this, read down the list. And it depends on what kind of job they're doing as to whether and which of this is relevant. So take notice at the top that the top half is showing you chemicals and substances, dusts and such, and the bottom is showing you everything else. Next slide, please. And in terms of chemical exposures, these are the ways people get exposed. Maybe you remember this from your training in school. Contact and inhalation are the two most common ways of getting exposed to chemicals in the workplace. Ingestion is more common at home when somebody's mixing bleach and ammonia, or a kid is getting into the cabinet under the sink. That's not so common in a workplace. Next slide, please. So in taking an occupational history, it doesn't have to be so complicated. There are lots of different forms, but asking the person what kind of business or industry that they have worked in during the last year, what kind of business or industry does their employer undertake? What's their employer's activity? That's the first question. And the second is you're asking the person about their job title or the kind of work that they actually do. And so you can ask, what kind of work do you do? And you can give them examples, and then they'll give you some kind of job title. It doesn't help you if they say I'm an associate, which is what everybody likes to call their employees. You really want to know what their job title, their descriptive job title is. Next slide, please. One could also use a calendar to get a longitudinal history. So if you're looking at cancer, I've seen this in the literature where the person is provided with a calendar and they're asked questions, you know, when was your first child born? When's your birthday? This and that. And you sort of anchor the calendar like that. And then you ask them where they were working or what they were doing at that time. And you can spend a little time and fill that all in. Next slide, please. There's another really great resource you can get on the web, which is called ONET Online. ONET is from the Bureau of Labor Statistics, I think, or the US Department of Labor. You can type in, here you can't see very well, but you could type in a job description or a job title, and it will spit out a bunch of information about that in terms of the hazardous exposures. Somebody's asking if extreme workplace heat and cold temperature is an occupational hazard. It certainly is. We would call that a physical hazard, and it's actually listed in the slide set that I showed you. Thanks for that question. Next slide, please. So I am pretty done with this. I hope I've convinced you that knowing about people's work and taking an occupational history is important, and you could practice with someone at home or even a patient, take an occupational history and really zoom in on the kinds of job tasks that they do, and see if you can fill out that form and put the hazards into the categories there. Next slide. These are the various groups that I work with at the School of Public Health. Please feel free to contact me or to look at our website. We have lots of resources and materials that might be useful to you. Thank you.
Well, thank you very much to both of our presenters. Those were quite interesting presentations. And
Thank you.
I think that we only had that one question. I don't know if anyone has any other questions you'd like to put into the chat here. David, I had closed that other presentation. I don't know if you have it open where you can give them the link for the CME, the CERT test, and then how to get credit, or do I need to open that up again?
I'm posting the link in the chat right now.
Okay. We can wait a minute and see. I just wanted to give people show that slide again. So close here, because I think you can hover your phone over it, right? Just open that up again. Share. Okay. Let's come to the end where we can see that. Where you can contact the IDPH Medical Services Division, but I mostly wanted to get to this slide. Oh, put in a plug. If we announce these presentations, they are at the same week every month. And so we do send out an announcement and registration through Siren, and it's a good thing for clinicians to sign up for Siren. It's the way that IDPH communicates about both educational opportunities like this, as well as emergency COVID. I'm sure you remember we sent many things out, and so a wide range of information that we think is important for clinicians to know comes through Siren. And then finally, here is, we can leave this up for a minute. The information for getting continuing medical education for this session. And did you say you put the link in the chat too, David?
I did.
Okay, great. Do we have any questions? Other questions? Someone has raised a hand. Are you able to let them ask a question? Anjet Macy?
Go ahead.
Anjet, did you want to ask a question? Maybe her hand was raised inadvertently.
Can you guys hear me?
Yes.
Okay. Yeah, I was just wanting to get the link to the ONET slide, the link that was, yeah.
Okay. We go back to Dr. Forst's slides. That's a good one. And these slides will be sent out also.
Oh, okay, great.
Yeah.
Thank you.
But I can pull that up too. We have 2 minutes still and time. Oh. Apologies. Dr. Forst has departed, so just going to close this other slide set. Pulling that in by mistake. Okay, we will go here. And find that slide real quick. Sorry, close your eyes. was in here. Oh, I might have gone past it a little too quickly. Here we go. ONET. I don't know. Oh, here we are. Do you see that link? I can try to grab that slide, that link, and put that in the chat also. Good question. Okay. Here's the ONET link. Everyone. Anything else? Otherwise, I think we're at time. Thank you all for joining today for this wonderful webinar, and we will see you again next month. Thank you.